To find out what your cardiothoracic surgeon wants you to know, I reached out to Dr. William Cooper. William Cooper, MD, MBA, is definitely not your average board-certified cardiothoracic surgeon. Dr. Cooper is a visionary healthcare leader, author, and speaker with a passionate interest in healthcare quality and safety and health education, a 35-year U.S. Army reservist who served 4 tours of active duty in Iraq and Afghanistan as a battlefield trauma surgeon, and the founding medical director of the highest rated heart bypass program in the state of Georgia by Consumer Reports, the Society of Thoracic Surgeons, and the National Quality Forum. He's won several awards, including the Georgia Hospital Association Hospital Physician Hero, the Citizens of Healthcare Physician Champion, and the Atlanta Tribune Magazine's Man of the Year. Dr. Cooper, first, thank you so much for your service.
Thank you. Thank you, Dr. Bright. It's been a pleasure to be here with you.
And second, I have to ask, you had a tremendous journey in terms of the contributions that you've given to the, not just the field of medicine, but to people in this country. I'm curious, what would you say triggered your journey to becoming a cardiothoracic surgeon?
The stimulus, or the as we sort of talked about earlier, the thing that got me into medicine was my mom's passing at a very young age. She was young, 46, and I was 14 years old. When I got to medical school, however, I really, and that was all about, she died of cancer, pancreatic cancer. And so that was all about wanting to get in there and cure cancer. And learn how.
At a very young age also.
Yeah,
really young age. Even for pancreatic cancer, it's a super young age.
Yeah, it really is. And but when I got to medical school, it was really, I went to a 6-year medical school, the University of Missouri in Kansas City. I want to give it a rah, rah, rah. I think it's the best medical school in the world. You're young. The attrition rate is high, 20%, but if you can get through those grueling 6 years, you're going to be a fantastic physician. So anyway, that's my advertisement for my alma mater. But, when I got there, I really, in just the way it was set up, they put you in a white coat day one, and you are shadowing a physician. You had clinic, and you had what we call the docent, and you would shadow that person once a week, every week for 6 years. I mean, it got more intense as you got more experience later on. But that was really, there was something that was very, very confidence building in doing that. But when I got to the practical aspects of it, I mean, of course, I was very interested in biologic sciences when I was younger anyway. But when I started getting into clinical aspects, I just realized that I really enjoyed the hands-on, and it fit with my personality, sort of wanting to see that immediate gratification. Oh, this guy got a big bulge in his groin, he's got a hernia. Oh, let's fix it. 2 weeks later, he's feeling great. So I really, that for me just fit. So, but I certainly enjoyed, all of my classmates got, they're getting their revenge now who went into psychiatry. People are like, oh, that's so boring. Nobody wants to go there. It was so intriguing to me. Some of these experiences with people who legitimately had these multiple personalities, and to watch. I mean, so I was really just very enthralled and really, really immersed in the medical school experience. So it's very interesting to me. I follow Twitter and following some of the new, it's that time of year, new grads are starting residency and all this stuff. I'm like, what was the hard? There was no hard class. I was interested. I mean, I'm being very honest. I was just very interested, and I knew this was going to be my life. So I wanted to immerse myself in it. And so, some tough nights and all those other things, but I wouldn't trade that experience for anything. But the hands-on piece was really the thing that got me wanting to do surgery. It's kind of the macho thing back. Everybody's going to do cardiovascular or ortho or neuro. It was all this stuff. And the popular rotation for a lot of the guys, some of the young ladies, was the cardiac surgery rotation. So I ended up doing a rotation following in the footsteps of a lot of the other egomaniacs, medical students, and really great group of surgeons. They gave you a beeper back in those days. There were no cell phones, or you had to keep it at your bedside or whatever at night. And literally they called me in one night, and I was like, they're not going to call me in. They said, yeah, they're going to call you. They said, yeah, they will call you in. I was like, you felt like, this is it. I got to go in. We got a case. You know? And so I went in and I started, was doing this case. And here's a little funny story, part of that. So the guy who was doing the case was he was just getting out of his fellowship, Jeff Kramer. And so he's in there, and it's a mitral valve replacement, urgent, in somebody who was having an infarct. So he needed to do 3 or 4 bypasses as well as replace this mitral valve.
An infarct is
a heart attack. Oh yeah, sorry. Yeah.
Okay.
Sorry for the audience. That's a heart attack. That's when you lose blood flow to a portion of your heart. Jeff is in there doing this case. And so I'm a medical student. I'm supposed to be second assisting, because one of the partners would always come in to first assist. And I'll never forget, I was standing there towards the end of the case. And I think Jeff left the room, and then his partner came over to kind of close up and kind of start doing, his partner's Hannah. These guys are up in Kansas City. Hamner's still around. I think he's officially retired now. But I just remember sitting there. It was a real life epiphany for me. Something just hit me and said, you know what? You can do this. You're going to be doing this one day. I mean, like a voice from heaven. I mean, it was really surreal. And
now, remind me, this is when you were still a student.
Yeah, I was still a student.
Yeah. Okay. What year student were you?
In the 6-year program, I was a 4th year.
Okay.
I was a 4th year in the 6-year program.
Okay.
And I'll never forget that experience. I tell people about that all the time. It's like one of those really vivid dreams. And so the irony here is that 30 years later, okay, I very briefly during COVID took another faculty position at the University of Kansas. And so I'm work on faculty at the University of Kansas, and the surgeon who's there, who's from Kansas, who's working with me, is Jeff Kramer. I tell Jeff that story, and he's like, he can't remember. He's like, he's back in those. He said,
there's no way he's going to remember.
He's like, he said, I have no idea what you're talking about. I said, yeah, exactly. This was like, you were a new attending. It wasn't your first case, but you got called in the middle of the night to do a mitral cabbage. Ham came in and helped you, and I was a student who was assisting you, a second assistant you.
Awesome.
Yeah, he still can't. I can't. He's like, Coop, I can't remember. So yeah, that's it. That was just a hands-on thing. It's just very satisfying. It just fits with my personality, and I really love the fact that the heart it has so much more meaning than just being this anatomic physiologic structure to me. There's something energetic about the heart that really, to me, transcends, or really is that deep connection we have to everything around us, that energy that a lot of people talk about.
Well, Dr. Cooper, what brought you to wanting to become a physician in the first place? Why did you say, you know what, I want to go to medical school, I want to become a physician? I was
always very interested in, sciences. We dissected earthworms and small rodents or whatever else in high school. I really liked that. It was very, very interesting and intriguing to me. But of course, the thing that really, tipped me over was my mom, developing pancreatic cancer and ultimately dying from that. I was 14 and I think I was a freshman in high school, and she was 46 years old, 8 children at home, and I'm number 7 out of 8. But that's pretty devastating. But that was the thing that, I was like, I'm going to go and become a doctor and cure cancer.
And then you have this experience as a 4th-year student, and you're like, you know what? I'm going to put my hands in folks' chest and massage the heart and keep it going.
And the experiences, having that early clinical experience, and that's why I really enjoy it. I'm so grateful to my medical school. But having that early clinical exposure is so important. You can read it in a book, but to be able to see it at the bedside and practically, and be able to connect it with the things that you learn in the classroom is really very powerful about that. And so, it's one of those things that just really, really gave me that ability to discern the things that were going to kind of fit for me later on in life.
What does your cardiothoracic surgeon want you to know?
When you first reached out to me, Virgie, and I thought about that question, it took me back to my days when I was doing a lot of patient education and speaking on behalf of my hospital and the university, and doing a lot of outreach to the community and things like that. And I remember I used to struggle with one question, because there's always somebody in the audience who would ask, what is the one thing I can do to prevent heart disease? Your question is a little bit different. I really used to struggle with that because you need to do all these things. You need to exercise, eat right, not smoke, keep your weight down, all these other things. Your question didn't ask for one thing. It just says, what does a cardiothoracic surgeon want you to know? The general theme is that I want you to know that in spite of what you may think, the ultimate outcome for your health, although highly dependent on our healthcare system, highly dependent upon our environment, highly dependent upon our lifestyle choices, to some extent, to a very huge extent, as we saw recently with this Roe v. Wade decision, interconnected with political issues. So we have the political determinants of health, we have the social determinants of health. But what I want people to know, and I can put more colorful context around this, is that really the power lies within you, the patient, the person, the individual, to really experience wellness. And so when you think about health, I think more about the physiologic, the absence of disease and all this other thing. But I think about wellness goes beyond that, because to me that wellness implies that you are now insulating yourself from all these other factors that you have no control over. And so my overall message, and the message that I've been about my entire life, has been that. I didn't know that, however, when I set out on this journey. It evolved through my mom, who died of pancreatic cancer. Later on, I lost a younger sister in '99 to diabetic ketoacidosis, undiagnosed, having urinary tract infections, which is, as you and I know, could be an indicator of hyperglycemia, yeast infections. Went back and forth to the doctor getting antibiotics for UTIs and whatever else. And she's admitted to the hospital and died, admitted with a blood glucose of 600. And all the physicians out there know that that's blood sugar for layman's terms.
Let's tell our audience, normal blood sugar is between 70 and 100. It should be no more than 100.
Should be less than 100. Yeah, even when you eat, your body's ability to metabolically control that. People who lose that control will see spikes in their blood sugar and blood glucose. So yeah, she was a diabetic and died of ARDS and diabetic ketoacidosis, induced ARDS, and died about a week after she was admitted to the hospital. I had another sister, Virgie, age 37, who had a heart attack at age 37. And then after heart surgery, to repair some of the damage that was done by the heart attack, she died after heart surgery. My discipline, my specialty, at my hospital, as a matter of fact, performed by one of my partners, my mentor, as a matter of fact. She was a smoker, had been told she had asthma, being treated for asthma, and finally she got so short of breath she had to go to the hospital, and they found out that she'd had a heart attack, and she died after heart surgery. That was September the 12th, 2001. In 2006, at this point now, I'm a faculty at Emory and attending. And as we discussed, your friend, our mutual good friend Keith Milner and the 100 Black Men, I was in part of the 100 Black Men back in those days, and it was late May 2006. We had our big fundraiser called the Cabaret, and I'm sitting there. My father brought my father to town to experience this event in Atlanta. And we're sitting at the table, and at this point, in 2006, now my cell phone's going off. Now we got cell phones, text messages, and all these things, and it's coming from family members. If you're in a big family like mine, it's coming from family members who you hardly hear from until someone dies. Mm-hmm. So I'm like, oh boy, what is this? So one of the twin boys' brother, the youngest of the two, Alvin, had dropped dead of a massive heart attack.
I'm sorry, one of your twin brothers.
No. Okay, let me give you the order. So it's older sister, mm-hmm. It's brother. So older sister's Janice. Next to oldest boy is Alex. We called him Maxie. Third oldest Vicky, who died of the heart attack. And then there were two twin boys, Alvin and Calvin. Okay. After Alvin and Calvin, the order kind of shifts. It goes back to the original order, which was girl Shirley, me number 7, William, and then Nicole number 8, who died of the diabetic.
DKA.
Yeah, the DKA.
Untreated,
So
undiagnosed.
Alvin was one of the twins, right?
Okay.
So he was a smoker, and and things like that. And I mean, he was a thin guy. I didn't know him to be an exerciser or anything like that.
And how old was he?
45. And so apparently they found him in his apartment, and autopsy showed evidence of an MI. The interesting thing about that, and this is to the point, what do you want your cardiothoracic surgeon to know? He's a smoker. He knows he smokes. About 3-4 years prior to that, I got a call. He was admitted to a hospital down in Arkansas somewhere. I was down there, and he literally was in the hospital now at around 40 years old. Okay, having a bypass or endarterectomy on his femoral artery at 40 years old. I'm like, wait a second, what's the lesson there? What do your cardiothoracic surgeon wants you to know? Okay, is that if you're a smoker and if you've got blockages in your leg, you've got them, guess where? In your heart, in your brain, in your kidneys, in your lower extremities. You've got them. You've got it everywhere, because it's a systemic illness. It's a systemic disease, and so that smoking and whatever other substrate underlying that risk factor that you have, it affects everything. Okay. And so interesting, he called me about this. I actually remember talking to the doctor. I remember saying to myself, this is very strange. I'm like, a bypass on his leg. They want to do this endarterectomy. He's having claudication and rest pain. I'm like, okay. And I remember asking him, did they check your heart? And he said, yeah, they checked me. I'm good. I said, well, okay. They're going to do this surgery. So he went through the surgery, he did fine. But, when that happened suddenly, I said, doggone it. He had coronary disease at that time. It wasn't diagnosed. And quite frankly, I wonder, did they do a stress test before the surgery to kind of look, I know he didn't have a heart catheterization, but yeah, he died of an inferior infarct and at age 45.
So, I have to say,
sure.
When I hear that, when you said, did they check your heart? And he said, yes, they checked my heart. Well, you're asking a layperson, was your heart evaluated? And you asking a layperson, did they check your heart, is different than asking the physician who's getting ready, the vascular surgeon who's getting ready to do the endarterectomy. Okay, so he's a smoker. He's got this claudication. He's got a blockage in the arteries feeding his legs. So before you take him to the OR, what workup do you do to check his heart before you take him to the OR?
Yes.
And It's really, really tough to get that message across to people that smoking is, head to toe, systemic, like you said, disease. And I find that many people think that if you're a smoker, they call them, cancer sticks and all that you're going to give yourself lung cancer. No, I tell people, no, that's actually unusual, even among smokers. What you're going to die of is a heart attack, or you're going to suffocate to death, emphysema, COPD. You're not going to die of lung cancer.
That's exactly right.
It's a systemic problem, head to toe, stroke, heart. Yes. I'm just going to go there, Dr. Cooper. A lot of men, that just breaks my heart when I see people smoking, but definitely men, in that it's often a way of, it's soothing, right? We do it when we have anxiety and that kind of thing. And it's something that, nicotine in itself is addictive, but it's something that is kind of like self-treating a form of, if we have an affective disorder like anxiety or something. But, to get when I have an extra in when I'm talking to men about smoking, and then I tell them, your stuff is not going to work if you keep smoking. You're concerned about dying early. Be concerned about not wanting to live, because it's not going to work, and Viagra is not going to help.
Yeah.
It blocks, smoking causes blockage from head to toe, and it goes with the smallest blood vessels first. And, what's that mnemonic we learned in med school with the spinal cord? S2-3, floor keeps the penis off the floor.
Yeah. Now you're taking me way back, Virgie. Oh my God.
So, it just breaks my heart. And so instead of, I try not to lecture, and because people aren't going to respond to lecture if they're addicted to lecturing, right? If you're addicted to something, that's not going to help. but I'm trying to figure out something that scares them more than death. And for many men, it's not being able to get busy, you know?
Yeah. I mean, this is interesting you brought that up. But yeah, back to the early part of your comment was you're right. Asking a layperson that question. And again, hopefully we'll get back to this when I talk about what I'm doing now. About this is that, well, I'm just going to go ahead and put it in there. You know, the reason why I started Primo Health Partners is just that reason.
Primo Health Partners is your company.
That's my company, primohealthpartners.com. If you want more information, we started on a telemedicine platform. It really, you know, we sort of kind of went out there with this idea of a second opinion, but it's really not about that. It's about partnering with us to help you navigate very difficult situations like that. And when I think about that, I think about my brother, my sister, and everybody who died, who just had those questions. They didn't know what to ask. But if you ask them, they would say, well, yeah, check. Guess what they did? They did an EKG.
Exactly.
Okay. Well, you and I know.
Checking my heart. Exactly.
You and I know that if you're not having a heart attack, an EKG, the sensitivity for picking up cardiac disease is almost zero.
Exactly. It's useless.
You know what I mean? So
it's a waste of time. Yeah.
Let's just keep it. That's
not what you're doing.
You have to interrogate. Okay. And so to that point, and then you bring up the issue about cigarette smoking and how it affects arteries systemically, and of course, men is absolutely. This is very interesting because. You can look up, and for those in the audience, I did a Steve Harvey show a few years ago. And one of the questions is erectile dysfunction, an indication potentially of heart disease. And that is the reason why, because it affects small blood vessels in your body. So men, the message is what your heart surgery wants you to know. If you're having problems down there, you probably should go and get your heart checked, because you could be having, you probably got a systemic issue in addition maybe to testosterone and some other endocrine and neurologic things that just come with aging. But you really need to make sure, because how many times do we have to say it, that heart disease is the major cause of death and morbidity in the United States? And back to my very big generalization here is it's largely related to decisions that we make. Lifestyle, the choice is yours. And, you know, another thing I also want to just throw out there, women, I see in my practice a lot of young women smokers. And let me tell you something, women, your arteries are a little bit smaller than men. And guess what? Atherosclerosis and buildup of plaque and cigarette smoke doesn't care. So I see some really, really difficult problems in young women chain smokers who, you know, because now we've got these little tiny arteries we've got to work on, and it just increases the more. And, you know, after heart surgery, quite honestly, the data suggests that, you know, all of the morbidities and mortality is higher in women. So, you know, we cannot ignore, again, cigarette smoking is a choice. You don't have to do that. Another thing I want to just put out there, since we're on this topic of smoking, is, you know, cigars are kind of trendy now, and you got these cigar bars and places like that. Let me tell you something. You know the data, Virgie. You're getting a whopping dose of nicotine and a bunch of other things through cigars, more so than you would get perhaps even from one cigar than you would get in one full pack of cigarettes. Mm-hmm. So there's no comfort in that. I mean, the chemicals are still there, still tobacco. Also, we have to just be honest. I mean, you know, we across the country, people are beginning to open up to marijuana. A lot of positive benefits to marijuana, but you got to also remember, sometimes those things are packaged with the same chemicals and tars and other things that go into other products that you smoke. So if you're going to engage in that, you really got to make sure that what you're getting, whatever you want to call it, organic or pure, or not being, you know, influenced by some of the fillers and things like that.
Infiltrated.
So, infiltrated, yeah, because I mean, the packaging and commercialization of this stuff can change the whole makeup of it. All right. So that's 2006. And again, still staying on this thing of what your heart surgeon wants you to know. Mom, pancreatic cancer, having back pain, bleeding, man, dig in, you know, double down on that. And all of us here, we all have an aversion to being sick. So when we go into it's kind of a double-edged sword, because we go into the doctor and the doctor gives you maybe even a superficial level of comfort that, oh, I'm okay. Doctor said I was fine. They checked this, they checked that. Well, you know, but you know something's not right. You've got to really begin to demand that, hey, look, something's not right. I know my body. We can talk about how you can get in tune with your body a little bit later. You know, died 6 months after her diagnosis, less than 6 months after her diagnosis. Younger sister, urinary tract infections, having this craving for ice and thirsty. Those are all potential signs of diabetes. Not always, but it is. Even in a young menstruating woman, it could be a sign of just anemia, which you need to know about also.
Mm-hmm.
Yeah, pica.
Yep.
And so, sister, diagnosis of asthma. Well, she had some of that at childhood, but she didn't have it as an adult. So it comes back, and now that's the easy pathway. She's got asthma. Well, no, she didn't. She had a heart attack and that damaged her heart, that made her heart valve weak, and now she's got to have a defibrillator and open heart surgery. Brother, smoker, doesn't exercise. Got a family history now because you've got a sister already that's died at 41. Strong family history. That's the other thing. You got somebody in your family had a heart problem before the age of 40, 41, or certainly before the age of 50 even. And major risk factors, that puts a target on your back. You are at risk, okay? And so you need to discuss that with your physicians and demand a comprehensive evaluation appropriately according to the guidelines and according to what your heart's telling, your intuition, and those things that you should be doing on a daily basis to just stay in tune with your health. Just to get us up to date on the question at hand. So we fast forward a few more years to 2011, okay? And several years prior to that, my older brother, I got a call. He was hospitalized in California, in San Francisco, as a matter of fact, Oakland actually. And so I'm talking to the doctor, and I'm trying to figure out, and what's going on. So it's a kidney issue, okay? High blood pressure, kidneys, creatinine's elevated, don't think he's going to need dialysis, but, we're kind of checking everything. We want to make sure that, there's not some infectious process, all these other things, blah, blah, blah. So what the doctor was trying to tell me without saying it and violating HIPAA is that my brother was suffering from HIV-related nephropathy.
Okay, so nephropathy is illness of the kidney.
Yeah, so
the kidneys are
HIV
damaged from complications of HIV infection.
Exactly. And so that's 2006, 2000. I kind of got it. I mean, Alex, we affectionately called him Maxie. He lived, he was in the military, I knew he was gay. He never said it though. He never came out of the closet. And you just imagine growing up in a small conservative town, even among Black people in small rural America, you just didn't talk about that stuff. Back in those days, even in 2006, it wasn't, that just wasn't something that was mainstream or even accepted. Okay, everybody wanted to just stay in their own gender in terms of what you think people ought to be based on how they look and their gender. But anyway, I always wondered then, and I couldn't ask, it's not my job to ask him or to interrogate him about something like that. But she was like, well, we're going to put him on some medicines and things like that. And I said, okay. So I saw him in the intervening years. He looked good. Looked healthy. He would come and visit from time to time, and we would have our family reunion in August. And I said, okay, well, maybe we're good, and I never asked. And so in late 2011, I got a call from my sister, the one that's just older than me, Shirley. And she said, hey, I need you to call the hospital in San Francisco. They found Maxie kind of wandering the street. The police were calling. They took him to the hospital, the doctors, and he had my number in his wallet. And so they called me. And so I called them back. And again, so this doctor was a lot more forthcoming. And she said, I don't know what you know about your brother. She said, but your brother has HIV and AIDS. I was like, wow. She said, we think he's got AIDS encephalopathy. And I was like, wow. I said, really? I said, I kind of knew something was going on there 5 or 6 years ago, but, I didn't know. And I've seen him in the intervening time. He actually looked okay. It just seemed normal. But sure enough, he had lost a ton of weight, almost unrecognizable. He was emaciated to some extent. My sister went out and got him and brought him back to her home in Missouri, and eventually we were able to get him in a nursing home. He eventually died of literally systemic AIDS in early 2012. Now, I've been in medicine for a long time, over 30 years now. And I can't tell you the last time. I mean, really, I just cannot tell you the last time I saw someone with AIDS. It's probably been 20 years.
Exactly.
And I'm thinking back on it.
Completely preventable. It should
Yeah,
not,
I mean,
progress to AIDS.
yeah, you're a physician.
Absolutely.
We
It's a
just
chronic
don't.
illness. HIV is a chronic illness. It should never progress to
Absolutely.
AIDS in this country, in this wealthy
Exactly.
country.
And so, at the memorial service, several of his friends came from California, and they said, yeah, we tried to get him to take his medicine, but he wouldn't take it. He said he just didn't trust those pills. What do you want people to know? It's okay to have a level of distrust, but follow up the distrust with responsible inquiry. Ask questions.
Yeah.
Go to someone like me or Dr. Ellington and say, hey, look, I just, something's not right. I just don't feel right about this. Help me with this. I mean, I'm struggling with it. It's oftentimes just those little conversations. And this goes out to physicians too. Just stop it, guys. Stop, sit down, get out of the rat race and start taking care of people, period. I mean, I can't tell you, I have to counsel young physicians all the time. Don't call me with this. Anyway, whole nother conversation. We'll do another podcast on
Yeah, that is another conversation.
As I told you, I'm getting into coaching and talking to physicians and
What
stuff.
older physicians want younger physicians to know.
Yeah, exactly. I mean,
But
some
you're
of us,
saying in
some
the
of us older
context
physicians,
of-
some of the
sorry.
older physicians are worse than the younger ones. My God.
yeah.
Some of our contemporaries are absolutely horrible. I don't know how they even got here. But anyway, whole nother story.
Again, another story for another day. You're absolutely right.
So he
but
got
you're saying
it.
that 80%, and you said this to me, Dr. Cooper, you said 80% of what I treat is preventable.
Yeah.
You said, we make decisions all day, every day. Our life is in our hands. And you're talking about an example of your brother made a decision he had his life in his hands. He made a decision to not take medication, treatment. Okay, because he didn't trust it. But to your point is we have the responsibility, with gifts, right? Come responsibilities. We've got this gift of these beautiful bodies, and we have the responsibility to take care of them. So if there's one treatment that you don't trust, then to your point, and you said this earlier, talk to physicians, find someone that you can talk to who you do trust.
Right.
And thank you for illustrating that really well with, unfortunately a sad story about, and I say this a lot, by not making a decision, you're making a decision. So by, ignoring it, you're still making a decision.
The decision is made. You're absolutely correct. Now to 2014, just prior to, it's probably around March 15th of 2014, I got a call from, I got a call on her birthday because I called her, couldn't get a hold of her, but I finally did. My older sister, Janice, this was March 18th, was her birthday. And she was, hey, I was saying, so how you doing? Happy birthday. How's it feel to be? She was almost 60, not quite. She said, well, William, I got some bad news. She said, I went in the other day and got my annual pap smear, and they said they saw some what looks like cancer cells on the pap smear. And I said, oh, really? I said, okay. I said, so what are the next steps? Well, I got to go back to the doctor, see, I guess, the GYN doctor in week after next, and do some more tests. So they do confirm that it is indeed cancer. Now, she is uninsured, okay, but is eligible for Medicaid. And so they start working through all of that. Now, mind you, this is March 18th, and she's got a malignant cells on her uterus at her age, late 50s. That's a hysterectomy. And obviously you do all the testing to see what stage it is and all those things. So now that's March. By the time she gets in to see a surgeon, hold your horses here, audience, it's June.
It's 3 months before she can even have her consultation with a surgeon who's going to do the hysterectomy.
Small town Missouri, no insurance, access, lack of resources, you name it. I said, look, I mean, I was on the phone with her on her birthday. I said, look, get all the records. Please go over there and just get the records, send them to me. I'll take them to whoever here at Winship Cancer, again, at Emory University, which, I'm affiliated with, one of the top cancer centers in the world. Let's get going, let's go get this stuff. Called her back a couple of weeks later. Well, they said they were trying to get it together. It was so just, and I'm sitting there thinking, okay, all right, Janice, what's going on here? Is this just local or is this, what's happening? No, but she's going to need surgery. So now it's June when she gets the surgery, and they do hysterectomy, salpingo-oophorectomy, whatever. But here's what I learned that I don't think she knew that they found at the time of her surgeries that she already had liver mets. So they just did the surgery. They didn't combine it with going ahead and putting in a chemo port or anything. So she gets through the surgery, gets discharged, gets scheduled to come back to the hospital.
Oh my gosh.
Now in late July, August for the chemo port. Now I saw her the second Saturday in August because that's our family reunion in Missouri. She came, she said, oh yeah, I'm going in next week. I said, Janice, this has been since March. What is going on? She said, well, the surgery went well. She had lost a little weight. And I think she probably wasn't really telling me the entire story. And I don't know.
So you're not sure if they told her that she had liver mets?
I don't think they did, according to the doctor because she said, on her deathbed, she told me that she didn't know. And
okay.
It was, but here's just, we'll go back and we'll break this down as we go through, when we get through this. So now that's August. She goes in to get the chemo port put in, gets there. The doctor who they scheduled her to have this procedure with is not qualified to do it, can't do it.
What?
Just a radiologist, not an interventional radiologist, a regular radiologist. Like, I don't do these. Okay, let's reschedule again. So now it's September. Actually, she didn't end up getting any chemotherapy until October.
Because they couldn't get, she couldn't get to an interventional radiologist to put the port in to get the chemo, to start the chemo.
And of course, it has everything to do with insurance and not having. Of course. It has everything to do with that. So she finally starts the chemo in October. It's too late. So I get a call right before Thanksgiving, literally Friday before Thanksgiving, somewhere along in there, 2014. She's in the hospital, just, having pain and just having some difficult issues. And so I drive to Missouri to see her, and she's there in the hospital. And what's happening is, I walk into the room and I immediately knew what was happening. Because the smell was just, you couldn't wash that smell away. She had pelvic sepsis.
Sure.
Literally, the cancer was eating through her vagina and rectum.
And the bowel. Yeah. And the rectum.
You just can't, you couldn't, that smell, I was like.
Distinctive.
I knew immediately what was happening.
Right.
And, now she's got ascites and almost immobile, lower extremity edema. So, and then it becomes the hassle of trying to, or they're hassling me now as someone who perhaps has resources. Oh, are you going to pay for her to go to the hospice or rehab? I said, you know what, guys, you do what the right thing. This is not about me paying for this.
I'm sorry, Dr. Cooper.
Yeah.
Who is asking you about the resources to pay for this? The facility?
Yeah, this is the hospital asking me, the social worker they're sending, or the care man,
gosh, the discharge planner, the social worker, who's
care
the
manager,
coordinator.
Yeah. Are you going to sign financial responsibility?
Are you going to sign this document to agree to the financial coverage of the bill of whatever we send you?
That's where their head is, Virgie. That's where their head is.
Yes.
We finally get her into a hospice or a nursing home, actually, because hospice, nursing home in these little small towns, it's all the same. But she died on, was it Christmas Eve? Or the day after Christmas, December 26, 2014. So what does the doctor want you to know? What does your heart surgeon want you to know? What does your doctor want you to know? It's not just necessarily about being a heart surgeon. It's about being a physician. Number one, she's doing the right thing, getting her, checked out, okay?
Her routine screening care, her routine health maintenance, she's doing everything right.
Mm-hmm. And I don't want to, cast blame, but my sister's never been one, she's not a conflict kind of person. She's not me. We're polar opposites. I mean, I would have tore that damn place up to get what I need. I mean, and I kept trying to tell her, Janice, please just go in here, get the records. I'll send you the money to get your husband to drive you to Atlanta. And it just never happened. I think there's a level of despair there when somebody who doesn't have the kind of resources that they need, I think somehow they just give up. They just say, so many times you go and you ask for your records, you're trying to get an appointment. You go and the appointment is not the right person. You're having surgery. You don't get the right information. You don't even know what your diagnosis is. I mean, it goes on and on and on and on and on. So embedded within all of those stories. So as I sit here today, I'm one of 8 children. I'm one of only 3 of those kids that's still alive. Thank God, my dad's still alive. He'll be 90 next year. I got the kids and grandkids and everybody working on, preparing for his 90th birthday party. Mom's deceased. So out of the 10 in the family, 6 of us are deceased. But if you think about all those stories I just told you, embedded within those stories is just about everything that's wrong with healthcare. Access, lack of resources, uninsured, timeliness, the right treatment. You just go on and on and on with all of this rhetoric that these organizations put out here about, this high quality healthcare system. Embedded in those stories.
If you can pay for it, sure, it's high quality. If you have the money to access it, yeah, sure. Right. If you get there.
Right. And so to some extent, that's why I created my company, Primo Health Partners. And we're going to change our messaging a little bit away from the second opinion and move more towards the messaging that is about us partnering. It's Primo Health Partners, and that word means something. We want to partner with you. We want to help you navigate these very difficult times. But to some extent, we've been hypnotized by the healthcare system. And I'm learning this as a startup business. And that is this. And here's what I also want to say to people. You need to invest in your healthcare. And here's what I mean by that. Everybody's so caught up in insurance. My insurance won't cover it. Well, guess what? Your insurance also doesn't cover your funeral.
That's right.
Okay?
That's
your premature death.
Say it again.
Your miserable quality of life.
Yes, sir.
Don't cover that. You need to invest in your health. And so when I say that, I mean also that you need to invest the time and the energy, just as much as we invest time and energy into taking care of our car. We take the car to the shop sometimes. More. We go to the car wash more than we go to the doctor. Or at least you don't need to go to the doctor that much, but more than we even think about our health. Think about that.
Yes.
The guy shows up at my house every week or two to wash all the cars. Think about that.
Yep.
Just think about if you put that much in, the guy's sitting there in the driveway for 4 or 5 hours washing these cars. Just think about if everybody was, every 2 or 3 weeks, you don't need 4 or 5 hours. You need a lot less than that. You need 4 or 5 hours in terms of exercise per week, 30 minutes a day, 6 days a week, getting your heart rate up to 220 minus your age. Okay. So if you're 40, that means you should be able to get your heart rate up to 180 and sustain it for 30 minutes. That has been around forever. Now, the data, we can argue as scientists and physiologists about the worthiness of that data, but that's pretty good data, okay? And so that's one thing you can do. And if you think your insurance is a health plan, you are sorely mistaken. It is not a health plan. Think about that, Virgie.
You're absolutely right, Dr. Cooper.
So I used to do these community outreach things for the hospital and the medical school. And I just asked the question, who in there has a health plan? Everybody weighs it. I mean, literally, it's typical. 80, 90% of people in the room raise their hand. I said, tell me about your plan. Oh, I got Aetna. Okay. What do you got? Oh, I got Humana. I got Blue Cross Blue Shield. What's yours? Oh, I'm Doc, I'm 65. I got Medicare. Okay. I said, let me ask you something. What is the health plan? And they said, well, I get medications. They cover my hospitalizations. I said, really? Interesting. I said, okay, that's great. I said, so what about keeping you away from all of that stuff. Tell me about that plan for what we call health as well as wellness.
Wellness. What's the wellness plan?
What is the wellness plan that's attached to this health? Because if you don't have a wellness, you don't have wellness, you forget about the health plan. It's going to do exactly what it's designed to do, which is take care of your illnesses. But hopefully, the way health insurance works is that you will pay your premiums until you die and never have to utilize it. It's risk pooling. It's the way it works. That's why health insurance companies make a lot of money.
Say that again, the last part again, because
it's risk pooling.
It's risk pooling. Yes,
yeah,
absolutely.
A bunch of people collecting a lot of money and trying to figure out how they can manage the 20% that drive almost 90% of the cost.
Yeah, it's an actuarial game. It's, accountants, it's a gamble, and they take the risk. It's why, you don't bet against the house. This is their house. This is their world. You don't bet against the house. They're going to win every time.
Every single time.
Yes, sir.
So what I'm saying here, Virgie, is really, as much as we invest spending all this time on, and even now our contemporaries, even older people now on TikTok and Instagram, doing all these weird, just pause for a moment. And especially young people, why don't you take some real good videos, and real good selfies. Everybody's got a little profile and commit to doing this. Commit to maintaining that level of wellness and vitality that you have today, 20 years from now. That's called enjoying life. That's called walking the talk, and living the life that you have been gifted through the grace of God. Just commit to it. You see all these Instagram models, and they're, doing all these and showing us the latest workout moves, and these guys on there all cut up and everything. You're like, okay, great. What I need you to do is commit to maintaining that for the remainder of your life.
It's in your hands.
It's in your hands. Absolutely.
Thank you so much, Dr. Cooper. I cannot thank you enough. This is priceless. Where can folks find out more about you and what you do? And where can folks find you?
Sure. So my website is www.primo, Primo, healthpartners.com, primohealthpartners.com. That is my website. That's our telemedicine website. You can reach out to us. If you just want to talk, we're there for you. Okay. If you're a physician, you're transitioning and you want to get some, even patients, whoever, you can also reach me on my personal website, which is drcoopmd.com. There's a lot on there about me. If you want to reach out and get some good coaching, I'm now a certified IPEC coach, and would love to hear from you and share with you some of my experiences, but it's not about my experience. You've got to create your own experience. And so part of what I do is to help you unlock the best of that experience that you can. And I have a team of people. Obviously, I don't, I'm just honestly, I don't have time, to service every single person. I try, honestly. You certainly will get to reach out. We're going to be doing some webinars and things like that, both on the coaching side as well as on the lifestyle and health and wellness side as well.
But you're training your team, Dr. Cooper, the Primo Health Partners team, to do the advocacy work that you lead and that you teach.
Absolutely. Yeah. And here's the other thing.
Perfectly said.
I do want to just mention this, because this is a product that we'll hopefully be bringing online later this fall, is that I think we're probably going to be one of the first telemedicine, telehealth companies to offer an on-demand telehealth services. And now you say, well, some of them that's the way it works. Well, you kind of have to call in, set up an appointment. But the way this works is it's a membership. And what we do is and we're actually going after small businesses, and we're trying to get people who, like my sister, no insurance, no resources, access is horrible. Just imagine if she had Primo around today. She can get on the phone. She can get on the phone with me, of course, but we get on the phone with oncologists and other people. It would be a lot more efficient that way. But our product is going to get people on demand. So you call in with an issue, and as a member, generally within 30 to 60 minutes, you'll be getting a call back from a physician.
And when this arm, the telehealth on-demand access
Mhm.
arm of Primo you think will be ready to launch when, Dr. Cooper?
In the fall. Yeah, we'll be ready to
Okay.
launch that in the fall.
So
And
by
that's
the
one
end
more.
of 2022, this calendar year.
Yep.
All right.
We are different than most telehealth and the people, and even the physicians that I recruit. Oh, what are the hours? This is virtual. You can do this at midnight if you want. I don't care. I mean, just take care of the patient. I mean, do it when it's Saturday morning, sitting on the beach, as long as you are engaged with what's happening.
That's the
We can
definition
also,
of on demand,
that's
24/7.
evident. Yeah, we're
Right.
24/7, 365. Again, what problem are we addressing? Access,
Access.
information. As a
Right.
member, if you just have a question, hey, just put me on this new medicine. I can't get a hold of the doctor. What do you think about this? And get patients call me all the time. Hey, doc, they put me on this Lasix and, my weight is up. I said, well, okay, so what did they tell? So first of all, I ask you, what did they tell you now? Do you remember when they said, weigh yourself every day?
Mhm.
And they probably gave you a little algorithm. Okay, if the weight is up more than a pound or two, take an extra dose later in the day. Okay. And then if it's still not going down, then, for a day or two, then you need to give us a call back and let us know. Oh yeah, they did say that. I said, it's okay. But remember now, in these very high paced, high stressful environment, you can't remember that stuff. So you want to do it. And so we try to create an environment that is a little less anxiety provoking, and give you the opportunity to really just take a step back. When I see patients, I'm not sitting there flipping through a chart and, having a conversation. I mean, you can't do
Looking
that.
at your computer, looking at a computer screen, a monitor.
Trying to
Yeah.
satisfy the EMR
Exactly.
God.
Documentation. Yeah.
Yeah. So we just
keyboarding instead of looking at the patient when they're talking to you. You have to listen so you can keyboard at the same time within the 15 minutes at most, ideally 10 minutes you have to get it all in.
Exactly.
Yeah.
There you go.
Good stuff. Dr. Cooper, thank you so very much. And I just, you've really, I know that you've blessed a lot of folks today. Thank you.
Thank you so much.
All right.
Bye.
Ciao.